let's drill down on just the overall impact on the Black community in Boston. Dr. James, you're on the front lines at Boston Medical Center, and before we had any of the data, you must have suspected that there was this disproportionate effect of COVID-19 on the Black and Brown community. No doubt, right?
Absolutely. As you said, no doubt. I mean, as you know, Boston Medical Center is a safety net healthcare system. And what COVID laid bare for the country is laid bare here 24/7 for decades. And in fact, we could have predicted the outcomes and the data that we saw in terms of how it impacted communities of color across the country. We are familiar with, and we really sort of understand the root causes of that type of data and the impact it had, because we engage with our patients to understand why they come in the hospital repeatedly, why they get admitted multiple times in a year, why they show up in the emergency department multiple times, over and over, same people for the same reasons. And what we've come to know because it begs the question, what would it take for this not to happen again? And it's a question that we ask patients, and at least I do, and the patients will tell you, and what we have learned from that is that they really cannot prioritize health, because they're basically trying to survive. And so they are in this space and not able to prioritize health because they are coming from communities that have been disinvested in, which created these structural barriers, a structural racism, essentially, that has prevented them from being able to achieve the sorts of things that enable people to thrive and certainly to weather something like COVID. And I'm talking about things like financial stability, opportunities to create those kinds of things for yourself and for your community, financial stability, economic mobility, and opportunities to build wealth. All of these things sort of are protective factors for you when you are stressed by a certain type of a crisis. And so those types of inequities that it leads to impact health. And when our patients come here, we basically treat them for certain. But what we're really doing is resetting them back to baseline. And then you wind up discharging them back to exactly what's driving it. And so I hope this has been a bit of I know it's an awakening, but it's certainly maybe a reckoning to understand what we need to do, because we don't need to invest more in trying to do something different in the same way. We need to address the root causes. We need to disrupt it and make it so that people can be independent, self-sufficient, and able to prioritize their health.
And Adrian, I want to go to you, because this kind of dovetails with something that you've said in terms of the conditions that cause what we're seeing now are not unique to COVID-19, but part of society in general. What were you trying to say by that?
I mean, as Dr. James said, there's nothing physiological about this, okay? What's driving this are all the inequities we see every day in the lives that people lead every day. And if anything good comes out of this, which remains to be seen, I hope it will be that we will begin to come to terms with the structural issues that lead to this kind of tragedy, because it's so preventable.
I'm wondering, Tanisha, why do you think, I guess many of us are just sort of waking up and saying, oh, wow, this really is bad. Why did it take so long for many people to realize that this was happening? Is it because we were just all dealing with this mysterious illness, something we hadn't seen in the past, and we were just scared and focused on survival and not really looking at some of the people who were really being hammered by it?
Well, I think there are a few things at play. Certainly, as Dr. James noted, the COVID-19 pandemic, public health pandemic, really highlighted the real deep health disparities that have existed for quite some time. This pandemic also exposed the very deep economic inequality that exists even here in the Commonwealth. And both of those aspects of the COVID-19 pandemic have been, from a data standpoint, seeing the data points. We've seen reported in the media. What we haven't seen as much of are the other issues and disparities that this pandemic has exposed. Adrian alluded to them when we think about education, when we think about the impact of this virus on our young people, and how, quite frankly, we're looking at a situation where, children left in March, and who knows when they will go back in. And yet we're still having conversations about how do we fit old education models into this COVID-19 reality, when for what our conversations really should be about is how do we rethink, reimagine education similarly to how we are now in the process of rethinking and reimagining what policing looks like. It's also exposed, of course, as it relates to housing. And we cannot forget that while much conversation has been around our urban cores, this virus also hit 351 cities and towns across the Commonwealth. And one of the consistent threads has to do with poverty. And we really have to get to the point, if we're going to have a meaningful conversation about race, we also have to be willing to have a deep, intentional conversation about poverty, even in the Commonwealth.
Well, look,
Dr. James, I want to go back. Oh, go ahead.
The city that's been hit hardest in Massachusetts is Chelsea, right? Let's look at it and think about why. You think about who lives there. You think about the income level. You think about a city full of people who can't work from home. You think about people who've had to go to work during this pandemic. It's been a petri dish of inequality. And it's a perfect example of all the things this is exposed.
Absolutely.
But why is that happening? That's an important point. But why is that happening? And Mr. Parsons from Manchester, New Hampshire, asked this question, saying, why we live in this progressive state. Why is this happening here? I mean, it's probably progressive. Maybe this should be happening somewhere else, but not here. Why here?
Mm-hmm. Well, I would respond to that quite simply, that even for progressive, liberal Massachusetts, we have yet to really wrestle with our own history and current existence with racism. We have certainly all of the resources, one would think, all of the resources to have avoided the outcomes that we're seeing as it relates to the COVID-19 pandemic. But the reality is that we still have structural racism to wrestle with here in the Commonwealth.
We also have to live in a state. Oh, sorry, Adrian. Sorry about that.
No, go ahead.
We also live in a.
James.
Thank you. I'm sorry. We also live in a state that has quote unquote universal health care or health insurance. Over 90% of the residents of the Commonwealth have health insurance, and it's not exactly having the impact we would hope it would have, because it's there, but people can't exactly prioritize it, because they're so busy trying to use what limited resources they have to, for housing or food insecurity or transportation or whatever. They can't think about using it for prescriptions and co-pays for healthcare and things like that. That's definitely not going to be a priority for them. So I agree with both what Adrian and Tanisha said, and I think it's like if we can put these things together. I mean, I think we do have resources, but we have to put these things together, understand the intersections, about how structural racism impacts all of these various different things, despite having all these resources and not changing the outcomes. That's the level of intentionality that we're going to have to put to trying to change things.
Dr. James, before we move on to another subject here, I do want to bring up one question from an audience member having to do with the medical community. This person said, what would the panel suggest doing about policies that a hospital's trustees create without any racist intent, but which predominantly adversely affect people of color, and how does that intersect with class?
I mean, I think first of all, it has to be a realization. It has to be a reckoning. It also might help to, with who you have on the board, how awake and aware people are who you have as members on the board. But there has to be. You said that they may not do it intentionally, but there has to be some mechanism of recognizing it there. So that has to, that has to be the case. Somehow you have to do that. You have to be intentional about and look for that kind of stuff, those kind of things.
I want to weigh in on that as
Tanisha,
We're talking a lot about anti-racism.
Oh, sorry.
Tanisha, go ahead, Tanisha.
We have to get to the point where we push past this idea that if you're a good person with good intentions, that the outcome doesn't matter. And in this moment, right now, when we have seen across the Commonwealth people from, again, every background saying, oh my goodness, I did not realize that this is what racism looks like. People across the Commonwealth are saying, Black Lives Matter. The next step to that, the next step beyond simply protesting in the street or saying Black Lives Matter, is to understand that if your actions, if your policies are having an adverse impact on people of color, on Black and Latinx people, and that's not your intention, then you need to be willing to disrupt that policy. You need to be willing to change that policy. It can no longer be, it's not our intention to cause harm. In this moment, we have to be intentional about focusing also on the impact.
And I think you'll hear that more and more now as this conversation continues, right? It is out there in the public, everyone's talking about it. So perhaps that's what will cause those in the medical community or others who've been hiding behind the intentional excuse to really start looking inward, right? And then making those changes. I want to move